Hi, good evening. My name is Uloma Oko, and I will be presenting on the benefits of using a midline instead of a PIC line to prevent CLAPSI. So, a brief introduction: peripherally inserted catheters, which are the PICs, and midlines are two of the most commonly used intravenous vascular access catheters. PIC lines and midlines are associated with different levels of risk and complications in different patient populations. And through numerous research studies have been conducted assessing the efficacy and safety of these PICs compared to midlines in the reduction of CLAPSI. While evaluating the available evidence of PIC lines and midlines, it's beneficial in informing best practices for intravenous therapy and basically choosing what catheter or which catheter will be best based on specific patient needs and basically evaluating each patient by a case by case basis because all patients are not, cookie cutter. They all differ in terms of their disease process as well as their immune response and treatment as well. So the PCOT question posed with this project would be in adult patients requiring intravenous therapy in an inpatient setting. Is the use of midlines more beneficial compared to PIC lines in reducing intravenous catheter-related complications over a 6-month period? So the significance, basically the problem of why this change is important is because catheter-related bloodstream infections continue to pose significant challenges to patient safety and care in the clinical setting, as well as CLAPSI being a severe complication that arises with the use of intravenous therapy for fluids and medications. CLAPSI is basically characterized by a bacterial organism that is introduced into the bloodstream through the insertion of these catheters, um, probably from improper technique or lack of hand hygiene or basically insertion procedure in terms of adequately disinfecting the skin before inserting these catheters. CLAPSI, excuse me, is usually accompanied by a fever within the first 24 to 48 hours after insertion of these catheters. Over 250,000 patients suffer from intravenous device related infections annually due to the use of these catheters, as well as the cost of treating CLAPSI is relatively high, with the treatment for this bacterial infection ranging from about 32,000 to 69,000. The major concern with CLAPSI is that it leads to, we've mentioned risk and complications and health risk. To be more specific, we'll talk about sepsis, this CLAPSI leading to sepsis, which could lead to multi-organ failure in these patients. And CLAPSI causes significant patient complications, leading to prolonged hospital stays, health complications, and higher healthcare costs for all involved, both the hospital and the patient. So, review of the literature. The article search was kind of challenging. The search for this literature, which had to be evidence based because this is an evidence based project, it was vital. The articles were sourced from PubMed, Medline, and CINAHL. I may have gotten a copy from Google Scholar. The search targeted studies published in peer-reviewed articles, of course. I tried to stay within the 5-year time frame. I'm not sure how research was affected by COVID in terms of this project, this comparing of the efficacy and safety of PICs to midlines. But some of the search terms I used were PIC versus midlines, midlines versus PIC safety, midlines, and PIC efficacy in patient populations. Those were the kind of words used. The search was limited to studies published within the past 5 years, like I said. And I searched about 15 articles, but really 10 were what was more qualified for the inclusion in this project. The decision to change practice, basically the decision is based off of the significance, the problem, the high mortality and morbidity rates in patients due to these CLABSI infections. CLABSI poses, like I said earlier, or mentioned earlier in the presentation, the significant patient complications, the financial implications to both patients and these healthcare institutions or facilities, as well as negative publicity of the hospital and the institution, images, and the high incidence of CLABSI in the country. This project was more or less inspired, the topic was more or less inspired by my clinical preceptor. She was unit manager at KP South Bay for the MedSurg Tele floor, and she was very big on infection control because they were typically the COVID floor, known as the COVID floor in the peak of the pandemic, and they still are considered the COVID floor. So she was very heavy on research in terms of infection prevention, and she was currently working on the I guess the evidence out there comparing the use of PIC lines to midlines and trying to figure out if midlines would be a better option to choose instead of a PIC line to prevent CLABSI in patient populations. But the research was kind of pointing towards, even though midlines are safer in terms of the reduction of CLABSI in patient populations, they increase the risk for DVT and thrombosis in patients as well. So a policy protocol basically boiled down to having patient nursing staff follow the policy and protocol of their facility when inserting these catheters and taking each patient case by case and determining the specific needs of the patient, because midlines could be used but no more than 6 to 14 days, so pretty much 2 weeks. The same thing with the PIC lines. Some of our patient populations, like our CKD patients or immunocompromised patients, cannot be on certain catheters, so it has to be the decision has to be made off of a case-by-case basis, and you would need to implement your hand hygiene and aseptic technique, as well as following your policy, facility policy and procedure for inserting these catheters. So embracing the findings of this research led to a policy on the use of midlines over PIC lines. The policy also requires the nurses to evaluate individual patients' cases as well as specific patient needs, also risk factors predisposing patients to certain risk when deciding on whether a midline over a PIC line is a better decision. Also, the policy requires the nurses to embrace the guidelines of midline use to reduce infections and also to be aware of DVT risk in their patient populations. So, in order to implement this plan, we would always adopt an evidence-based practice guideline to follow. These were some of the options I was considering: the peripherally IV with guided ultrasound, midlines, and non-tunneled catheter implementations to maybe cater towards specific patients and their specific needs. Also to organize seminars, workshops, and conferences for the nursing staff members to educate them and provide trainings of potential staff that would be initially certified on the insertion of these catheters. Also to set up a go live transition date to coordinate, monitor, and control the transition process by these designated staff. And lastly, we always have to evaluate and reassess our implementation or progress or plan, whatever it may be. We always evaluate and reassess in nursing. The evaluation. So during the evaluation process, it is key to determine the evaluation objectives. Like, what is our main goal out of this? Our main goal is to find out whether midlines prevent CLAPSIs compared to PIC lines. Is our design method feasible? Are we hitting anticipated are we making our anticipated progress? The engagement of stakeholders, it's always key to involve stakeholders in major changes to achieve this reform. Initiation of the evaluation process, we have to somehow initiate this process through either getting established pre-project data and also establishing post-project data on how far we've come. We also need to be able to monitor and control project implementation processes, and we always like to circle back for feedback from staff as well as follow up on any questions or concerns that may have arise during the transition to the change. So lastly, a little conclusion. The expected outcome at the end of the intervention is to have a reduction in CLAPSI incidences and DVT thrombosis, which concerningly, in my research, I found that both PICs and midlines can cause CLAPSI and DVT slash thrombosis, but DVT was higher with the use of midlines, while CLAPSI was higher with the use of PIC lines. And that's why I said it is better to circle back to your assessment skills and decide what catheter is best for your specific patient and their condition and their immune response and their disease process. Also, the evaluation will involve comparing the incidences at the start and end of the intervention. And in making this comparison, the nurses involved in the care delivery will collect data on the incidences during and at the end of the intervention, which was our PCOT time frame, which was at 3 months, and then again at 6 months. And then the evaluation will help determine whether the intervention was effective at reducing these intravenous therapy related complications like CLAPSI or DVT, whatever the infections may have arise through the complications of DVT, and to help us identify whether the progress made or whether the change made any positive impact on the rates of infections in our patient population. That concludes my presentation, and the rest of this would be my slides, my references, sorry.